No, this is what I love. And I just, okay.
We can tell, yes.
Thank you. Okay, EKGs. So make sure, I've already said AFib like 5,000 times, right? Chronic illness, you should take AFib. Okay, so you've got your AFib, yeah, Betty's got AFib, and, yes.
So, it's okay, so the readings in the book were only, pertaining these specific, the normal sinus rhythm, the sinus brady, the sinus tach. It wasn't talking about, was it including SVT or any other things, or was it just strictly the ones that were in the objectives?
Should be the ones in the objective.
Okay, because there was like SVT and PVC and
Well,
then
SVT
bundle blocks. and all
SVT is
this
an
stuff.
umbrella term, right, for
Yeah,
like
for
sinus
all
ties.
No, SVT is a thing, it's its own thing.
Oh, really?
Sinus
The book
bronchitis.
says it's an umbrella term.
No.
Sinus tach would be. SVT is a type of sinus tach.
Oh.
Just keep them separate,
Yeah.
just keep them separate.
Okay, so it's
VTAC, VFib, asystole. That's what I would do. Okay, I would just, this is it right here, okay? These equal death. So you kinda need to know what to do with them. With no pulse here, because you can have VTAC with a pulse and be okay for a little bit. Okay. So AFib, make sure that you know the implications, right? AFib is really dangerous because of stroke and PE and decreased cardiac output, right? We talked about the decrease, there's no atrial kick, okay? And then the treatment. So what are the drugs that we give for AFibers? They're gonna get DIG or a calcium channel blocker, right, like diltiazem. And then they're also gonna be on an anticoagulant, usually warfarin. Okay, and all the things that go with warfarin. That should be on another, AFib should be on another study sheet, read me all the time, kind of thing. And the INR, remember, if it's therapeutic, do we give the warfarin or not?
If it's therapeutic,
If it's
yes.
therapeutic.
Yes. If it's therapeutic, it's safe to give. If it's subtherapeutic, if it's low, you still give it and you anticipate giving more. Some people, if you have a question like that, client comes in with AFib, their INR is 1.5, and we know we want it to be what? 2 to 3. So their INR is 1.5, and it says you have an order for warfarin, 2 milligrams PO Q day. What's the nurse gonna do about that, right? Video stopped, really? It's your job to work. Well, it might be a two-parter.
I can just send you this one.
Okay. So, so the AFib, the patient comes in, they've got an INR of 1.5, they have AFib, and you have an order for your warfarin 2 milligrams. Do you give the warfarin 2 milligrams? Yes. You're still gonna give it. Yes, they need more, but remember, it's all about safety. Is it safe to give? Yes. If the INR is 2.5 and you have an order for warfarin 5 milligrams or whatever, do you give it? Yes, it's safe to give. It's therapeutic. You're doing what it's supposed to, it's doing what it's supposed to do. What if the INR is 3.1? Do you give it? No, you hold it. And you notify the doctor, whatever. Okay, but you have to remember, if it's therapeutic or subtherapeutic, it's still safe to give. It's just like when we have an antihypertensive and the blood pressure is 105. You still give it. It's probably 105 because they're on the antihypertensive. So you have to ask yourself, is it safe to give? Not, is this the best thing right now? Is the treatment effective, whatever? Okay, is it safe to give? So the warfarin, the INR, and then the therapeutic level, okay? And then the treatment, so it would be ablation, where they go in the cath lab and they zap the troublemakers, okay? They zap those, so they basically kill those cells that are causing the trouble. And then what do you think is in their place? Scar tissue, right? You just electrocuted a cell. It's gonna scar over, okay? And how would you know that the ablation was therapeutic? Because now the heart rate is 80 and they are in normal sinus rhythms. Okay, or, their heart rate was 170 before, now it's 90. It's still AFib, but it's a controlled rate. Okay? It's that kind of stuff that you gotta think about that feels kind of abstract. And then like the plan of care. So, what kind of nursing diagnoses, teaching, okay, what kinds of things are involved there? And make sure that you know what to do here when you defib, okay, when you cardiovert. And you can cardiovert if you witness the AFib go into RVR. Okay, it has to be a new AFib right now. If they've had AFib, it's a no-go. You have to use drugs, okay, or go for a surgical procedure, like an ablation. SVT, so a fast SVT, you could cardiovert, try to shock them into a good rhythm. Sinus Brady, we give atropine, right? But do you give everybody with sinus Brady atropine?
No.
No. Who gets,
An athlete or
they have to be symptomatic. That's all right, Rita's recording it. We can all thank Rita. Where was I? I lost my train of thought.
Symptomatic.
They have to be symptomatic. So if your patient has a heart rate of 40, but they're alert and oriented, their blood pressure's fine, they are not symptomatic, you do not treat. Makes you nervous, but they're fine, okay? So you have to make sure they're symptomatic. If they're symptomatic, you give the atropine. If you have SVT, cardiovert, but again, they have to be symptomatic. They have to have a low blood pressure, diaphoretic, not perfusing well, okay? We defibrillate VFib and VTAC only. That's all you defibrillate. That's it. You only, without a pulse. You only defibrillate these two pulseless lethal rhythms, okay? And then if you have torsades, we are gonna shock still, but you're gonna give MAG, okay? Your patient goes totally unconscious, they are not responsive. What's the first thing you're gonna do? Check for a pulse. You always assess the patient first. If the question says they have no pulse, you've already assessed it, okay? Your patient has no pulse, what do? What's the first thing, or the priority action? Compressions.
Contractions.
If there is no pulse, you start contractions. Ask yourself, I'm tired. Compressions, that is the most important thing. If you have no pulse, you have to compress the heart. Everything else will fall into place, okay? If you have a shockable rhythm, compressions are first, but you absolutely have to defibrillate them or you will not fix them. No amount of medication or CPR will fix a shockable rhythm. That's why they call it a shockable rhythm. You have to shock it, okay? Asystole, there's not much we can do except try to figure out what caused it and fix it. It's just chest compressions, okay? And you always, if you have a strip and you're going to treat it like you have asystole, you have to verify the leads. Because as you guys all know, they come off all the time and looks like asystole quite often. So if your patients, you always have to assess your patient. You think you have asystole, are they awake and alert? Because if they're talking to you, they are not asystole, right? Okay, all right, that's all I got, thank you.